and I'll let Aaron take over from here.
Hey, Rob.
Hi, can you guys hear me?
Yep, loud and clear.
Okay. Got a little bit of a moving camera. We're moving some stuff around the room here, but we have a very interesting case to show you. It's a little bit less complicated than Aaron's case, but I think you'll find it very interesting, and I think it'll bring up a lot of relevant topics for discussion. To my left on the camera here is our fellow Mircea Cristescu, and he's going to present the case this afternoon.
Hi, everybody. So we have a case for you guys of recanalization of an iliac venous stent, which has been occluded. Next slide, please. So we have a 44-year-old male with a history of unprovoked left lower extremity DVT here. His symptoms began in 2011, where he experienced spontaneous lower extremity swelling, which at the time, per the patient, was treated with what he believes to be thrombolysis and possible stent placement, and he was placed on warfarin at that time. He was seen again in 2014 for a reported recurrent episode of thromboembolism. We don't have a complete history of what was done at that time or where the thrombosis was, but we know he was treated using only heparin at that time as an inpatient and then discharged. He has persistent left lower extremity swelling and discomfort, which interferes with his activities of daily living. And past medical history is significant for hepatitis B. Past surgical history is listed below. Next slide, please. His medications, currently he was on warfarin prior to having been seen at Mount Sinai. He is now on Lovenox prior to this procedure. He has no family history of DVT or thrombophilia that we know, and his vitals are listed below, all within normal limits. On exam, he has 2+ edema of his left lower extremity from the calf to the thigh, with some significant hyperpigmentation of his skin in the shin and calf region. So he is a CEAP C4. He was worked up by our vascular medicine service, and he was found to have PAI1 heterozygosity, which predisposes him to DVT. Additional workup studies were negative. Next slide, please. And on our CT venogram performed February of this year, we see that he does in fact have a left common iliac stent, which we can see from our axial images has been stenosed, and there's low attenuation material in it and calcification. Next slide, please. Lower down, we note that the external is diminutive in size, and that extends down to the common femoral vein, and he does have collaterals, which you can see far screen right, because of his occlusion. I didn't include this on here, but he did get a lower extremity Doppler workup, and he does have chronic partially occlusive clot from his popliteal to the femoral vein.
Okay, so let me show you what we've done so far.
Rob, quick question.
Happy to take any questions that you guys might have already. But if we can, show the images. We had a very difficult time getting in, especially on the left side, and that's going to make this case even more slightly interesting for conversation in a moment. But obviously the right side was wildly patently. We were able to get a wire up, and now we have a stiff Amplatz wire up in the IVC. The left side was very, very difficult to get in. We finally spent about 15 minutes getting a sheath in. We were finally able to get a large sheath in, and you can see here, this was our run when we got the first sheath in, okay? And obviously the wire is not up into the IVC, but really brisk, robust collaterals around his pelvis. You can imagine how much venous hypertension this guy has. But of note, you don't really see a good common femoral vein. You get a hint of the saphenous vein there, but clearly not normal anatomy. And I'm sure you're all thinking of how I'm going to get myself out of this, but I'll take that question in just a moment. So we started to sort of work to try and dig through this, and you can see us playing with the glide wire. And I can tell you in my experience, when you get that loop in the glide wire, when you're trying to get through an occluded stent, this is sort of gold, if you will, because it's unlikely it's going to go through the interstices into a retroperitoneal collateral and get you lost. And so, that loop was really valuable. We were able to actually get a little bit more purchase on that loop, as you can see here, and get it to prolapse up into the inferior vena cava. Once it was up, we were able to track a diagnostic catheter up, as you can see here, tracking into the wall stent. And that would give us a little bit more support to be able to get the appropriate wire, not in a complete loop configuration, to go up. And so here we have the straight part of the wire. We're doubling over a little bit, and now the loop just prolapses up into the IVC, and we are in fact through. So we were able to navigate this without any sharp needles or any other adjunctive tools that Rahul had alluded to earlier in the day in his presentation. And so again, now we have a stiff guide wire through. We have large bore sheets in both of the common femoral veins. Here we're just trading up from the glide wire to an Amplatz wire. And I'm going to document that we're true lumen now, obviously, which we always do anytime we cross the CTO. And now we are pre-dilating this stent with a 5-millimeter balloon. Honestly, when we blew up the balloon on the top of the stent here towards the inferior vena cava, it actually ruptured the balloon. But we got a little bit of a channel going through it, as you can see. We're able to repeat that down here at the bottom end of the stent. And this pre-dilatation was really just to sort of try and figure out what our options were to try and move this case forward. We also further dilated down into the distal external iliac to try and at least make some inroads as to how we're going to get out of this case. And again, even further lower down, ballooning. And then this is our run where we are right now. So we have a little bit of a channel. You're still seeing those collaterals fill. And now I'm going to throw it back to you guys to say sort of how would you reconstruct this? You have a very, very symptomatic guy. Of note, I just want to impress upon you of how much, I'm going to zoom in so you guys can see what I see. Hold on. There we go. So if you see, the wall stent really does cross over completely to the contralateral wall of the IVC. And so we haven't really decided definitively yet what we're going to do here, but I sort of wanted to pause for a moment and ask you guys what you would do. The first questions that come to my mind are, do you treat it with another wall stent? Do you do kissing stents? Do you pre-dilate more before you introduce the stent? I can tell you this stent's been down for years. This is chronically occluded. This is not a subacute in-stent restenosis or a restent thrombosis. And so we're really just dealing with more or less a brick wall in this patient's left common iliac vein. And on that note, I'll sort of take any questions you guys have, but we are sort of ready to go based on what the panel says that we should do.
So, Rob, based on the history, it seems to me like this has been down for at least 4 years.
Yep.
And possibly longer. The first stent, it looks like that first stent was placed, and you can see there's 2 stents there. It looks like that first stent may have been placed in 2011, presumably for a May-Thurner type lesion. Would you agree with that?
I would agree with that.
And then it occluded, and then they placed another stent. So clearly, this is, it's pretty typical for chronic venous occlusion that these stents don't stay open forever. But is there a technology that exists that would allow us to sort of keep this open longer? And I think, you were alluding to this earlier about venous stents that are made for this purpose. This concept of sort of covering the other side of the cava and where to land the first stent. I mean, obviously you didn't place that first stent, so we can't really go back and change that. But what should we do about it now? I personally think that you should probably at least do kissing at the top on the other side. I don't know if the panel would do the same thing, but it looks to me like that's coming across the bifurcation a little bit more than I would have liked initially.
So since I just want to, I'm not saying that I'm really in the mood to do kissing, but I'm just going to make you guys a picture that's a little bit more conspicuous as to sort of what I'm facing here in case there was people that were on the fence. So here's the DSA on the right side.
Yeah.
So
you
Rob,
clearly see it's crossing over to the other side. Yeah, Keith, sure.
Yeah, the one thing I'll say is I have personally been burned by that before, in that on venography, and no matter how you slice it, it looks like you're well into the cava. But if you IVUS this stent, you could potentially find out that you're actually a little bit short. I know it looks like that, but sometimes then on my follow-up venogram where I know I'm just barely flared into the cava, on venogram it looks like I'm well within the cava. So I just bring that up because you didn't place that stent, and I think that you want to make for absolute sure that it is not shy.
Well, you know, the good news with this patient in particular is that the right side is not occluded, and if you have to put a stent here, presumably given that he has a mutation, there's a good chance he's going to occlude the other side too on follow-up at some point in his life.
So Keith, I think your point is well taken, and I guess I again would respectfully say, in this circumstance where I am right now, would you put in kissing stents, or would you just put in a left unilateral stent?
I would not put in kissing stents.
You would not. Okay.
Rob, I agree with that. I mean, I think Keith and I were talking on the side, and our biggest concern is where is your inflow?
Right.
I mean, you know, the picture you showed after you used the 5mm balloon was not convincing that there was any flow coming from either the profunda or the common femoral to get you into, even if you put a patent stent inside of this chronically occluded stent, getting enough flow through that to keep it open is my biggest concern. I think that the issue of kissing stents is actually secondary to that primary issue.
So this is what I'm going to do. So you know, I am obviously where I am, and so to that point, and this is why I didn't open up 2 stents. Obviously, I'm going to dilate the entire length of the stent with a 10mm balloon. Okay, and then I'm going to go down and dilate the common femoral with that same 10mm balloon, and see if we can get a little bit of clarity on this inflow issue. Does that sound like a reasonable idea?
Yeah, Rob, based on the CAT scan, where do you think the inflow starts?
Well, we really couldn't sort it out, to be honest with you, but I'll tell you, when I got my sheath in, there was like blood pouring out of the sheath. Okay, so there's definitely blood flow going into this area, and the question is, do we have enough inflow per chance, obviously. Now, obviously, this patient is hypercoagulable, and we're planning on anticoagulating this patient afterwards. And I'm just want to make sure that everybody agrees with my assessment on that. That you know, we're dealing with a chronic stent occlusion, and we want to be pretty aggressive. And so I was thinking about anticoagulation and antiplatelet therapy,
Totally agree with that.
The idea here, I mean, you can see it's actually opening up pretty nicely with this 10.
Well, you know, it looks to me like the occlusion probably ends above the femoral head, but, you know, it's hard to know for sure. I mean,
it is hard to know for sure. I totally agree with you.
Now, would anybody, a patient like this, would you access the groin even if the groin was open, or would you consider going down lower?
I would go lower.
Yeah,
I would start lower. And you know, I think this is exactly where IVUS is incredibly helpful, because you know, venography can tell you that it looks like there's great flow, but when you take an IVUS catheter in there, you'll be able to tell where the vein is most open. It's usually where either the greater saphenous plugs in or where the profunda plugs in, that you all of a sudden see open vein, and then above it, it could be closed off. Below it, it's closed off, but you know that's where you want to start your stenting, and it often is well below the femoral head, quite frankly. And so that's why, you know, I would try to start maybe even mid-thigh or popliteal.
Okay. I mean, these are all excellent points, and I'll be, you know, very candid. If I hadn't have gotten any blood return when we got into the common femoral vein, and it was, you know, slightly compressible on duplex when we got in, then I probably would have aborted and said that we should go into either the saphenous or go into some other access site. But in this specific circumstance, we actually did have blood flow when we got in. And we were able to send a wire up, obviously. Now, I don't know if the camera wants to show this, but this is the blood that's coming out of my sheath right now. And I certainly know that's not a strong indicator for anything, but it suggests that the common femoral vein, or at least the distal external iliac vein, is not occluded.
Oh, I think it's definitely open.
All right.
Yeah, and I think honestly, you'll fix all this in the iliac, and you could always come back and fight another day if it becomes an issue or on your follow-up image.
You could even treat this in the acute phase.
Did you guys see that?
Right.
Did you guys see that?
Yeah, we did. That flow through is really important. The fact that you're able to actually get that flow to go up there, that's really huge.
Right. So the actual, the actual contrast washed out. Which Aki, I think you were alluding to that. That's probably the most important prognostic sign, I think. So I'm actually going to back out the common femoral vein sheath. You can see I'm sort of tugging on it.
Yep.
I'm bringing it down to, I think, where we would all agree is probably the sort of, stenting point of no return, if there is such a thing. I don't think I'd want to stent below this. And I'm going to do a DSA run here. Then you guys tell me what you think I should do. I'm in your hands.
Does anybody on the panel put, when you re-stent these cases, and I think we all agree we're going to want to re-stent this, do you like putting wall stents inside wall stents, or do you have another option that you guys prefer to use, at least at this point?
I mean, I think that we don't have any great stent options, honestly, and I would probably err on putting another wall stent in. The only thing I've done, and now it's not going to even be available, if I had something central at the iliocaval junction, I've used Z stents up there before, just as just at the very top.
Rob, do you think you need to come down lower than the current wall stent, or do you think you're going to?
Now, there I'm actually out. You can see that, right? Mm-hmm. So what I'm going to do is I'm going to take my dilator, and I'm going to get myself back in.
How does the panel feel about stenting within the wall stent or going below the wall stent here and just doing angioplasty below the stent?
You mean extending the wall stent?
Yeah, because if you extend it down to, let's say, right where it crosses the iliac bone there, do you think that if it occludes in the future, which it probably will at some point, assuming, just the natural history of these stents, do you think that it'll allow clot to propagate into the profunda veins and things like that?
Well, so, I'll offer an alternative to the wall stent, and, this is my idiosyncratic practice. I cannot use data to back this up, but I do think nitinol stents are a little bit easier on the veins. And so the most peripheral stent I place is typically a nitinol stent, either a 12 or 14. And then I telescope from there into the previous one with a wall stent, such that the edge of the wall stent is not being traumatic to the vein itself. So for example, in this case, I would try to figure out where the vein is most open along the femoral head and start with the nitinol stent there that's short of the stent above it, and then bridge the gap with the wall stent.
So it's interesting because so if I were here, I would make sure that I was good up at the top, but let's say I wanted to go a little higher, I'd take a wall stent, and much like you, my lower stent would be a nitinol stent, but I'd do iliac central first and then protege or whatever.
And the reason I go peripherally first is because you're getting flow into your stent from the beginning. I've actually so I used to do it that way, and I had that stent clot on me because it didn't have enough flow going into it. So I found, that was my rationale. I think that was a rare case. It happened once, and that's what changed my practice. But I think that's it's interesting.
So I just want to make sure I got consensus from you guys. Kissing stents or just left-sided stents?
Left-sided.
Left-sided.
Okay. So does anybody think that I should not put a wall stent at the top right now?
Well, Aki did mention that,
On the top, meaning at the IVC.
yeah, and I like the concept of using a self-expanding non-wall stent just because you can deploy it a little bit easier and you can get it right at the junction where that other stent is so you don't go too far across. I mean, obviously you could use IVUS. At the same time, I think you can pretty accurately deploy a wall stent now because you've pre-dilated it, so.
So I think I'm going to put in a 16 by 90 wall stent at the top. I'm sure it's going to elongate dramatically, and we're going to post-dilate it, and then you guys could tell me what you think based on that.
Do you think that the stents that are in there already are 16 or 14?
I think they're 14. But again, I want to have a little bit more oomph on the top and on the bottom, and I want to be able to aggressively dilate them. I'm probably going to dilate them up to 14. And then see what I'm left with.
You know, it's unfortunate. I know when I've gone in an IVUS, the 16 millimeter wall stent, and you take it to 16, and then you go do your follow-up IVUS, and it is opposed to the wall, and then you're seeing the luminal diameters are like 8 by 10.
Right.
You know.
No, I totally agree with you, Keith. But the question is, I don't think.
Oh,
we
I agree
know,
with what you're doing.
Well, I don't think we know what the right thing is, and we don't think we understand what the implications of diameter sizing, certainly inside an old stent, are.
Right.
You know, and the other thing, which is just an interesting variable, and I don't have an answer for it, I have my own opinion, is that I only pre-dilated the stent channel up to 10, you know, maybe 10.5, but I certainly didn't pre-dilate it to 16.
Yeah.
And you know, my concern there is I just don't want to cause that much barotrauma to this stent that's currently in right now. Mostly related to issues about fracture and then whether I'm going to be able to sort of manage it with a stent on the other side.
Now, would anybody on the panel take this up to a 14 or a 16 angioplasty balloon and balloon the entire length and then leave it at that?
I would definitely angioplasty with a 14 or 16 and then line it with a stent. I think you're not going to get enough expansion on your wall stent unless you pre-dilate with a really big balloon.
So what do you guys think up here on the top? You like that or no?
Yeah, I personally, based on venography, I would go more central. I like where you are right now.
You want me to go higher?
I mean, you might start a little higher and then pull back a bit.
Okay, how about that?
I think that skosh
That looks really good.
Love that word.
Aki, do you always pre-dilate before putting in a wall stent up to the rated diameter?
I would consider a 14 or 16 balloon pre-dilate before placing the wall stent, yes.
Yeah.
What do you guys think?
Looking good. Looks good.
You got some room.
Pull it back or keep going?
I'd keep going.
Looks fine.
Any concerns?
No? Do you?
No, I'm good. I just wanted to let you guys chime in.
Yeah, looks good.
You guys will let me know if you need an echo, right?
Yeah.
I'm ready.
It's the right size. 16 by 90 is definitely the right size. A 1660 would have been a little short.
All right, we're at the point of no return. Anybody have any concerns?
Take it.
All right,
It's good.
done. Okay.
What balloon are you going to use to post-dilate that?
A 14 millimeter XXL. Probably starting in the middle.
What is everybody's favorite balloon for this type of application?
I use high pressure Atlas.
Yeah, I use the Atlas.
It's
Whatever we have in
frustrating,
stock, honestly.
I don't know if the panel has the same issue, but the number of balloons I've popped in these cases, especially trying to reline stents, is Atlas is or Bart is very happy with me.
Probably XXL will
when
pop too. I think 20% chance the balloon pops on the wall stent.
When I dilate this, so personally, I would go to the top because I think you have that intimal hyperplasia, or whatever it is on the middle of that stent. I would be a little concerned of just it watermelon seating up a little more than you want it to go. So that's why
Watermelon seating up or watermelon seating down?
both, but I think up would be my bigger concern because of the cava. I think that if you hit the top with almost some like backward tension, I think you're going to really like your result.
You have a lot of room on the bottom.
Yeah.
I think that's a
So I'm thinking I'm going to put another stent in on the bottom.
I think you might
Yep.
too.
Again, I'll listen to you guys, whatever you think.
No, I think we're with you on that, Rob.
All right. So what do you guys think? Here? Lower?
I'd take it higher.
Higher.
Higher?
higher.
Here?
Yep.
Okay.
And with some back tension.
Now, this is not a high pressure, this is an XXL. So the max, I think the rated burst on this is 6 or 8.
No way.
Oh, really?
Is that right, Rob?
Yeah, it's nominal is 5. Burst is 8.
Yeah.
So we're going to go to 8.
Okay.
All right, take it down.
So you mentioned that when you're done here, you're going to do anticoagulation and platelet.
Yes.
So what is he on currently? I just can't remember.
He's on Eliquis.
Okay, so you're going to continue Eliquis and then add Plavix?
I'm going to add, I think I'm just going to add aspirin. I don't, you know, I'm all over the place about this stuff. I'm really curious, Keith and Aki, whether you guys are doing anything differently, but I get a little bit worried about advancing people to a NOAC and Plavix because of the bleeding concerns, and I feel a little bit safer with the use of 81 milligrams of aspirin. And, you know, totally anecdotal. You know, we're outside the evidence base here clearly, but that's just where I find my comfort zone is in terms of mitigating bleeding complications.
Before we talk about that, Rob, did you hold the Eliquis at all for this procedure?
Yes.
What was your hold?
He's been on Lovenox for a week.
How's he like Lovenox? Because I like Lovenox. I know this may sound crazy, but I would talk to him about Lovenox for a month in this acute phase, and this may also sound crazy. I will do in somebody like this who I'm really concerned about, triple therapy. I would do aspirin and Plavix. He's 40, I think you said he's 40 years old.
Yes.
So I feel like I'm going to give him my best shot by that triple therapy. And then at a month, when I reassess him, and that looks pretty good.
Did that flow forward?
Yeah, it looks.
No, a little bit. It's
gonna have to
sluggish.
do it.
I will give it to you guys. It is sluggish down here.
It seems, I mean, in the middle of that stent, there's a lot of,
Stuff.
you know, clot, intimal.
Yeah, you see a little bit of flow there, but it is sluggish.
I'd like to see if you can get that stent open a little more.
So the I think I'm going to put in another stent, basically down to the inguinal ligament here. Can I have another 16 millimeter stent, 16 by 60, if we have it? And then I'm going to think about sort of how I'm going to get myself out of here. If worse comes to worse, I can always access his jugular vein and come down and, you know, reconstruct the common femoral vein into the deep femoral vein. I don't know if you guys have done that before.
Yeah,
I think that's a strong
absolutely.
consideration, Rob. I would strongly, if after this stent you're not getting adequate, you know, flow, I think you're in danger. And this is also why I agree with Keith on the triple therapy. If you have a suboptimal flow at the end of the procedure, I think you're sort of obligated to maximize anticoagulant and antiplatelet therapy. But I would also consider accessing the neck, like you said, getting down, trying to find that profunda, trying to find where it's most open, and going open to open in your stenting.
Mm-hmm. Yeah. So I'm just gonna ask the team to, just in anticipation for that, to get a 6 by 90 destination, and hopefully be able to use that in case we find ourselves in that unfortunate situation.
You know, the concept of triple therapy, I think, is interesting. Have you guys seen, with that therapy, have you seen a lot of bleeding? And the reason I ask that is because, you know, I personally see a lot more thrombosis than I see bleeding, and so it makes me think that you're probably under-treating a lot of these patients.
I don't see a lot of bleeding. What I will see at the end of that month is I'll have patients come in and they may have some bruises, but nothing that is...
Not a major bleed.
No, not at all.
I've had my older patients bleed. I've had a couple retroperitoneal hematomas, and it definitely influenced my thought process. But in a 40-year-old, I think that, like you said, the chance of clotting is higher than bleeding. But you have to be careful with your older patients. They will have their retroperitoneal bleeds.
In cardiology, obviously, we have quite a few patients on triple therapy, and I would echo the same thing like he said. A younger guy probably would be okay, and the stakes are so high, I definitely would do it.
This brings up, honestly, the whole idea of the increasingly low threshold for stenting May Thurners and our, you know, what we don't know 20 years down the road in these 20.
It would be great to be able to see what this looked like in 2011.
Yep.
Right.
In retrospect.
Because this is a difficult situation. It's a very difficult situation. We encounter it a little bit too frequently, I think. And, you know, stents within stents, we've all had that patient where you just keep stenting and you keep them open for 6 months and they come back. And we really need to, that's where C-tract is going to be very important to our ultimate analysis and the net benefit of what we're doing.
I think it also raises the question about whether these stents are even appropriate for this application. So I personally am eagerly awaiting 16 and 18 millimeter and bigger self-expanding stents for the venous structures.
I think that was a 16, though.
You think that initial one was a 16?
It's pretty big.
So we're dilate this external to a 12, and, you know, excuse me if I'm a little bit conservative with how I dilate all this fibrosis here. And then I'm going to do a run, and then, you know, we'll decide as a group as whether I'm going to access the jugular or not. And if I'm going to do that, I might have you guys give the final talk and then come back to give me a little time to get set up for that.
Does anybody on the panel post-dilate these stents with a bigger balloon than the stent diameter?
Generally not.
Generally not. Yeah.
I'll sometimes do the opposite, where if you have, sometimes I'll deploy an 18 by 90, for example, and only dilate up to 16.
Yeah.
That will keep, you know, a certain length that you want. You sort of play with the ability to modulate the length of a wall stent.
That looks a lot better. But you can see within the stent, I mean, there's a lot. I mean, down there it looks good. But within the stent, it's still a little narrow.
Yeah, it's really going to be whether I access it to a site that's just all scar or not. I think, you know, we've all sort of been there, and the question is whether I'm going to be able to sort of navigate this or not. I think we need to manually defect.
And Rob, I don't mean to beat a dead horse, but I would strongly consider, if you have it available, to try to get your hands on an IVUS catheter. Maybe not for this part right here, but if you're considering coming down from the IJ.
I agree with you. I don't think there's any downside to that, certainly. I think that if we're going to, you know, access the jugular vein, I think my target, unless you guys disagree, is going to be the deep femoral vein.
Or the, yeah.
as the source of inflow. And so if that's the case, then it's not clear to me where IVUS is going to be so helpful. You know, I'm not going to stent it, clearly. I'm going to balloon it. You know?
You may be surprised, actually. There might be a part of the common femoral before the bifurcation that's actually open, that you'll identify with IVUS, and then you're not going to have to stent all the way down into the lesser trochanter.
Or honestly, if you do come from above, you end up just angioplasting that lower segment anyway without stenting.
Yeah.
So I think we are getting into a bit of a mess. I'll show you what kind of mess we're getting into. Just a second. Actually not as bad as I thought.
That being said, clearly there's a lot of, I mean,
Oh, yeah, there's a lot of resistance in the common femoral vein. There's no question about it.
yeah. It's not a bad idea to come from above and see if we can interrogate that a little bit more, and I agree with the IVUS. IVUS is so useful in these venous structures, particularly down here where we have a difficult time visualizing them with conventional venography.
I'm thinking I'm going to go from the neck, put a 6 French sheath down, and then balloon the common femoral vein.
That's a good idea. I think everybody would probably do the same.
Yep.
So we can let you do that, Rob, and then finish up our last presentation, then we can come back to you. You tell us when.
Okay.
Hopefully about 10 or 15 minutes, and then we're going to be
All right,
finished.
hopefully.
Pretty
yep.
strong work so far, Rob.
Thank
Great
you.
case. Thank you. Okay, Rob, we're ready.
I'm ready. Okay, so we've been working unbelievably efficiently. I'm actually amazed myself we were able to get so much done in one lecture, but we actually were able to get a 6 French sheath from the neck down into the left external iliac vein stent. You might see the run I just did, but that's from the 6 French destination, which is in the external iliac vein stent. And you can see there's just a tremendous amount of fibrosis in the common femoral vein. And so what we're planning to do, it's not clear to me the other room's going to be able to go before the meeting ends. So for the next 5 minutes or so, I was going to sort of dilate the common femoral vein and see if I can get something that looks like inflow. If that's not enough, obviously off camera, I'll sort of dig for something that's a little bit more robust. But sort of this is where we are right now. Any questions or comments or criticism so far?
Where's the tip of your 6 French destination?
Yeah, I think you can see it there. Is that in the external, Rob?
Well,
Stop right there. Yep.
There you go. So you see the sheath in the external iliac vein. There is a glide wire looped down into this sort of circumflex femoral collateral. And I can sort of show you digging around a little bit, but I was not able to get that much farther in the time. I knew that Aaron was sort of wrapping up, but there's my wire. And I'm not sure if that's something worth taking, or not, obviously, but I was sort of digging around here a little bit. I obviously don't want to get the footprint of what I'm working with too big. And so again, the idea is just, I think, can I open up the common femoral, given the fact that I have a sheath there, to try and give us a little bit more inflow?
Rob, I probably would take maybe an 8 balloon or something like that, pull that groin sheath back over the wire, put the balloon down, balloon it up to whatever you think is appropriate, and that may be done. What do you guys?
So I think that's what we're probably going to do then. I actually like that idea. That's a good idea.
Yeah, I would definitely take that sheath out.
I'm not sure what that sheath is doing for you now.
I agree with you. I'm not sure what the sheath's doing either. So I think while we're sort of waiting for a balloon to come, I think I'm going to have Murcha take out that 11 French sheath in the groin, and we're going to get set up to balloon the common femoral.
A good fellow activity.
We talked about this earlier. You guys mentioned that you would possibly go into the popliteal in a case like this right from the bat. Do you still agree with that?
Yeah.
I think, look, you get where you are, right? We've all been in these situations
7mm balloon on a 130 shaft.
You don't have the ideal access, right? I think this is a great case because it shows problem solving, and I like what he's doing. But I do think that you could potentially go, but then
go from the top.
you potentially, depending on the side that's the stent, you'll be putting a 10 French sheath in the popliteal. The jugular, I like the jugular actually in this case, and maybe that would have been a great, if that happened at the outset. But
I think in general we underuse the jugular for these cases because we're so focused on the lower extremity, but the jugular can be an adjunct. The problem with jugular is that you sometimes have to put the patient prone.
No.
So, the thing is that, the dogma for IRs is to not puncture the femoral vein. And I think the reason that we say that is because you have nothing to compress against, right? So what I've found, though, is that the vascular surgeons tend to puncture the femoral vein more commonly. And you will get your set of hematomas, but we I've started actually using a closure device with a 10 French sheath, the Vascade. We published it. We have about an 80 to 90% success rate, which means that you have a 10% failure rate. I will completely admit that. But it also gives you access to this critical segment where you need to figure out where to begin your stenting process. So I've moved to trying to start my procedures in below the lesser trochanter if possible.
Yeah,
And it keeps the patient supine.
Right. We sort of always joke about femoral vein closure devices, but this is a great application for it, because compressing this vein at the end of the case, you're sort of
Take it off.
Yeah, but you know, quite
in
honestly,
reverse.
if he gets through that common femoral from above and he'll put up a balloon, I mean, it'll be fine.
So the only thing is, though, that what's making it easy from the IJ is the fact that he's done all this work from below to get it open. So you can imagine that the redundancy coming from the IJ might make it difficult to get through that stent, because you're pushing and you're bending the length of the entire system. And so I think that's one potential disadvantage, but as you guys said, it does give you the option of the profunda if you need to come from above. But I don't know, Keith, do you use the IJ commonly in these situations?
Yeah, my staff joke, like, if I'm doing these cases, I'll say, prep the right neck, prep both groins, prep the ankle. I mean, they get it all ready, because I don't want to be in a situation of having to have them do that mid-case.
I think you're a great IJologist. I've actually started doing a lot more PEs from the IJ because of you. I give you credit every time.
Looks like the sheath may be a little bit outside.
I agree with you, but I'm going to take a picture and try and tell you guys where we are in a second.
Profunda.
Walk this off on faith. Why don't you deflate it?
Yeah, I got it.
So interestingly enough, once we dilated that, we actually saw it, obviously, as you can see, that the wire is sort of tracking towards the deep femoral vein.
Yep.
And I know everyone's patient waitingly to go to the cocktail hour, so I'm going to try and make this.
Well, Rob, we have 2 minutes left, and then we're done with this.
We've actually
session
started over
for the
here,
day.
Rob.
So
Okay, thanks. I hope someone's saving me something.
I don't have anywhere to go. We'll wait for you to do this last run here,
Okay,
and then I think we'll close up.
I agree. And if anybody has any parting words of wisdom.
Any thought? I mean, Keith and Aki were talking about femoral vein closure devices. What are your thoughts on that,
Why don't,
Rob?
No, only I was.
Only Aki was.
Keith does not want to be
Keith is
associated
not supportive of
with
that.
such statements.
No, that's probably just extract from the venotomy, right, Rob?
Yeah.
Yeah, I think it's extra from the venotomy also.
Yeah.
but the interesting thing is you are emptying,
little bit better.
of outflow through your stent.
Rob, that looks pretty good.
Yeah, I think I'm gonna obviously go off camera, but I'm gonna work a little bit to try and find that deep femoral. I think that branch that's coursing to about 4 o'clock may very well be the deep femoral, and I'm gonna work on that for a little bit. But I think, again, it's washing out pretty rapidly, which I'm pretty happy about. I think this patient's gonna do okay. I think I'm gonna take Keith's advice and do triple therapy. And, we'll follow up at the faculty dinner tonight.
Just be careful of that extra, Rob, with the triple therapy. Just make sure you get absolute hemostasis there and hold extra pressure there.
Absolutely. Thanks, guys.
Thanks,
Thank you
Rob.
very much.
That was great.
All right. And thank you, everyone on the faculty. Great meeting this afternoon.
Great case. Thank you, Rob.
Okay.
Okay.